Good evening. I'd like to outset thank the organizers for inviting me for this conference. I thought I'll sort of take a tweak on the topic and making sense of chimney and sandwich grafts. I think you just all saw Sanjay putting in a chimney graft in the arch aneurysm case, which he did right now. And I was asked this question somewhere, that is it a substitute for fenestrated or standard repair? And I couldn't find a bigger font than I could find on this to fit on my laptop. And I think it's no. Chimney graft, although it looks very easy and Sanjay showed it done well, and we used to be very enthusiastic to do chimneys maybe 3-4 years back, but the sudden, I have come to the conclusion that, at least with my experience, that chimney should be only ruled as a bailout procedure, and only if fenestrated cases it's not suitable for a fenestrated stent graft, or it's for a ruptured aortic aneurysm where you don't have much time and you don't have a good enough landing zone. So it's a valid alternative for these procedures as for emergency setting, a patient unfit for open or hybrid repair, and no time to manufacture a fenestrated device. And even in this now, that if, I think Dr. Neelakantan is going to show you a very interesting case which we have done, is you can also manufacture a fenestrated device on table if it is suitable. But to go for the history, to go for the worldwide experience, it was started in nearly 2001, where we used actually branch stent graft technology for treating these results. But it wasn't so successful at that time, so Greenberg used renal stents to depress the proximal edge of a stent graft when he accidentally covered the renal arteries. And then they had something called a top fenestrating technique where, as Sanjay showed you, you could place pre-placed stents and work like a fenestration and aortic stent graft coming from the side. And they've got various names. You can call them chimney, you can call them snorkel, you can call them periscope. And the chimney stent graft was proposed by Orlando when covered stents were employed in a similar fashion. So you could use bare stents, or you also use covered stents. All the covered stents are preferable. So they have progressed from a nice journey from using bare stents, where they've used it when the carotid or the subclavian was accidentally covered, and progressed to using covered stents now, especially for these renals or sometimes even the SMA. This is how it looks for those who want to see what happens, how it's supposed to actually fit, although they rarely fit so beautifully, which is shown in this diagrammatic representation, was done by Orlando and Molina, where they've used chimney grafts, which is coming in from the side. It actually comes in from the side of the aortic stent graft on both sides, and they actually fit like this. And it may make no sense physiologically and anatomically for it to work, but surprisingly, they do work pretty well. And although we don't have a very long-term follow-up of more than 5 or 10 years, but the follow-up which I have for nearly 2.5 years, we've not seen any antegrade chimney stent occlusion. So it was published in the JEVT in 2008, where nearly 10 cases were shown, and there have been recent more publications on that, where they've used it for the carotid, subclavians, renals, and in certain cases for ruptured cases, even for the renals and the superior mesenteric artery. To show a case where you can get although this is not done by me, I borrowed it from Alina's article, you can do a case where you can cover up to the ascending aorta, put in a long chimney coming in from the innominate, and then do a carotid bypass or a carotid subclavian bypass. Or you can even put cases where you can put in a carotid chimney where you have accidentally covered the carotid artery. And it's supposed to work in the sense, the way that, as you can see these results, that they have had a pretty good result over nearly 20 months follow-up, and they do not say, they see no leak and no occlusion of the chimney grafts. There can be a primary proximal type 1 endoleak, which later on resolves, and it is feasible for urgent TEVAR in patients with an inadequate proximal neck. They've also expanded it to what the term we have sandwich grafts or snorkels, what you call, where it's supposed to replace what you call endo branching, where it gives extended chimneys. Seen in this case, where they have done long stent grafts put from the side, going from the both renals, reverse chimneys done for the superior mesenteric artery and the celiac, and reverse chimneys done for the renal arteries. So this is what you call maybe what you call your sandwich techniques or your techniques, snorkels, where you go from the side or put it in between two stent grafts. But there are certain issues which we have. They've got attachment site endoleaks which can occur. You can mainly have an endoleak like we saw in Sanjay's case, or they may close off. But what they say is, why does it work? Is because of the ability of the stent graft, of the peripheral stent graft to wrap itself around the parallel stent. And the longer the neck you use, the better the seal you're going to get. So in effect, what does Chimney do? It actually extends your landing zone, and it helps you to do cases which would not be suitable with a standard device. There have been pressure measurements done selectively, proximally, and distally to see that your chimney has been deployed well, and there will not be any result of any stenosis or blood flow reduction into the branch grafts. So initially, as I said, we started off with great gusto, around in 2 years, we did nearly 21 patients. Not a great proponent of doing it in the thoracic region because I think extra anatomical bypass work pretty well. But for juxtarenal AAAs, we've done around 19. We have had a few complications. We did one reverse chimney which occluded. We had a type 1 leak which was treated with an aortic cuff. There was a sheath slippage, hence we lost one renal artery because sometimes if it's a badly angulated one, you may lose the sheath. There was a renal pseudoaneurysm which occurred, which was successfully coiled in the same sitting. But in 2 years follow-up, the grafts were pretty patent and they did well. So just to show you a case, a 72-year-old man, angulated neck, large infrarenal aortic aneurysm, where we used a single chimney. Now this is a large aneurysm, as you can see here. This will not be so suitable for a fenestrated initially when you're doing it, but now I'm sure we can do, with the new devices, we can even do a fenestrated graft for this. But when I did this, that time fenestrated technology was still not available for us in India. So we did a single left renal chimney and put in an aortic cuff to seal the lesion, and you can see the final follow-up result here. The left renal artery chimney is well patent and the aortic aneurysm is sealed. Then there's another case of an 80-year-old man with a previous CABG, a juxtarenal aneurysm, operated, and he presented with an aortoduodenal fistula on an emergency basis. The surgeon ruled out an emergent surgery because he already was a hostile abdomen for him, old patient, a highly risky procedure. So he asked us to do a chimney where we've gone in and put in an aortouniiliac device here and put in bilateral renal chimneys for this procedure. Because the patient was highly unstable, done an emergency setting. Once we did that, when the patient stabilized, maybe after a month, then the duodenal patch was repaired. And this is a 2-year follow-up. You can see that the renal stents are well patent and no leak, and the patient's hemoglobin is now 13 grams. So the complications which I mentioned, sheath slippage, where we lost the renal artery, branch perforation can occur. You can also get a stroke when you're doing TVAR patients because you can have, while you're puncturing the carotids or puncturing the subclavian, you may get an emboli which can go up in the vertebral or the carotid arteries. And endoleaks, which is the main concern which we have if you don't get an adequate sealing zone. This video doesn't open here, but you can see there's a wire here, which there was a branch vessel perforation, which we have coiled successfully in the same sitting. So that sometimes with a bad angulation, you may require a very stiff wire to get support. And while you're doing that, the stiff wire may perforate one of these small branches, and that can cause a disastrous result. But luckily, it was seen in the same, meaning once we noticed it, we still had access, so we took a microcatheter in and coiled the pseudoaneurysm. So it looks very appealing, this procedure. It's still unproven and untested, and like Dr. Dietrich mentioned, that you have a smorgasbord of options and you can use them, but there's still no long-term basis of the durability and ultimate benefit which can be quantified still at this time. So where I would like to just put in my advice in this is that you can only use them where, I think, when your back is against the wall, when you have a ruptured aneurysm, it's too angulated, you don't have any choice and you want to salvage the patient, or if you feel the patient's an extremely high risk for traditional extra-anatomical bypass, especially in the neck, then maybe a chimney option would be feasible. There is data which has been published lately in 2010. The limited experience demonstrates abdominal chimney grafts is feasible and safe, but obviously there's no long-term and larger patient cohorts which will need to evaluate the utility of these devices. But to show you, once we got approval for fenestrated stent grafts in India, a case like this, where initially when we had this patient, Dr. Neelkantan and I were thinking, should we do a snorkel or a chip sandwich graft? But with the advent of fenestrated stent grafts, I think this is the way to go, where we can put in a fenestrated graft. Through that, we put into the celiac and the SMA, and we have an excellent result. As you can see here, patent celiac, patent SMA arteries, and with long-term data of fenestrated grafts, which I think someone is going to be talking on, I think it's a very feasible option to use. And with the advent of custom-made fenestrated grafts, which are available off the shelf, especially Cook is coming out with their devices, Ventana is coming out with their devices, where they can come off the shelf and you can be used for nearly 85 to 90% of cases. I think that's the way to go. So Chimney still has a role, especially where it's as a completely bailout procedure, but you need to be prepared with other hardware such as coils, and in case you have a perforation, and maybe extra Parma stents and balloons. And the long-term follow-up is still to be ascertained. It is a good alternative, but still not a substitute of the new technology which has come in. Thank you.